Dr. McCants is a licensed mental health counselor who holds a doctorate degree in counseling, psychology, and counselor supervision. She has expertise in trauma-informed care, maternal mental health, and counselor education. As a certified trauma specialist and trainer, she specializes in postpartum mood and anxiety disorders, traumatic birthing experiences, and social justice policy development. Her therapeutic approach integrates evidence-based modalities, including MBCT, a lot of acronyms, nurses, we're used to acronyms, CBT, TF-CBT, and narrative therapy, restorative breath work, and trauma-conscious yoga techniques. Currently serving as an assistant professor in the Department of Counselor Education at St. John's University, Dr. McCants' research focuses on understanding trauma's impact on the brain and body through polyvagal theory and neurocounseling. She has expertise in maternal mental health and perinatal post-traumatic stress disorder. She's licensed in New York, New Jersey, and Pennsylvania, and maintains an active role in professional leadership as the president-elect of, Neresis, and past president of the American Counseling Association New York chapter. Dr. McCants is the author of Soul and Bloom Wellness Workbook, which is also available in the back table. You can see that at the end of the event. A practical guide developed through her clinical practice to help clients cultivate self-awareness, build self-esteem, and enhance confidence. A vocal advocate for Black maternal health, she draws attention to the disproportionate maternal mortality rates amongst Black women during childbirth through her research, presentations, and professional trainings. Her expertise in trauma, postpartum mood and anxiety disorders, and trauma-informed clinical supervision informs her advocacy work and commitment to healthcare equity, particularly for women's birthing rights, LGBTQIA+ populations, and underserved communities. Her comprehensive approach to mental health combines clinical excellence with a commitment to accessible, culturally competent care and systematic change. Without further ado, please give a warm welcome to Dr. McCants.
Hi, everyone. So this is a different setup for me. So I'm usually used to being like in the center, but I have to hit this little button to help the PowerPoint go by. So you'll see me trying to manage between here and somewhere there. And I notice how far away everyone always is at one of these things, like you sit in the back. Hi. All right. Okay, so March is Women's History Month, right? So we talk about the concept of her story. You can't hear. Okay, so her story, honoring your past, embracing your present, and elevating your wellness, where you are today, thinking about your story and your journey along the way. So when we look at women's mental health, we talk a lot about the stages of life that we've been through, things that have happened throughout our journeys. And this slide here is just a bit about me. All right, so I'll keep going. Okay, so first, this is me, and Dr. Barnes, I thank you for that introduction, but how I started in my career. I started as a kindergarten teacher. That's that picture. Then I went into case management, and then what we call assertive and community treatment teams. And those are people who work collaboratively. So like mental health providers, we have social workers, we have nurses, we have psychiatrists, and we all work on one team to help folks who have serious and persistent mental health illness, and they live in the community. So we go out to visit them in their homes. And I left from the ACT team where I was a team leader. I went to work in hospital-based care at Westchester Medical Center. Then I went back to working at a nonprofit organization doing the same work with ACT teams and then also forensic ACT teams. Then I shimmied my way into higher education so I could shape minds of folks who want to be counselors. And then lastly, I started my group practice that I have in New Jersey. So that's a little bit about me. So we're going to play a little game here. And we're going to call it Spot the Mess. Let's see if this works now. It worked. Okay, so the first one, I want you to think to yourself, is this a fact or a myth? So the first one, So women's emotional responses are primarily driven by hormones. Fact or myth? Who says fact? Okay. And who says myth? All right, so it's definitely a myth. Other things play a part in how we respond in our emotional capacity. So we think about our biopsychosocial models, right? So biologically, my genes, what I've inherited. Then I think about psychologically, if I do have a mental health issue, and then all those social factors or environmental factors that play a part in my response. All right, second one. Postpartum depression only occurs immediately after childbirth. Fact or myth? Myth. Do you know how long it can occur after childbirth? Up to what? Well, on the books it's 1, but yes, 2 years. All right, this little thing. Okay, so the next one. Fluctuations in hormones throughout the menstrual cycle, pregnancy, postpartum period, and menopause can impact mood and mental health. Fact or myth? Yes, fact. Okay. So women are more likely to develop PTSD after experiencing trauma, despite men experiencing more traumatic events overall. This one's a little tricky. How many say myth? How many say fact? So the fact is like, maybe it might be a little, no, it's not. Okay. So the first part of this sentence, so women are more likely to develop PTSD after experiencing trauma. That part is true. However, that last part, despite men experiencing more traumatic events overall, that's not true. That is honed on the fact that when we look at research, we saw that men were experiencing trauma, but those were men who were veterans, who served and came home and had PTSD. But now when we look at this research, that number is much higher for women. Okay. Got a few more. All right, so women provide the majority of informal caregiving, which can increase stress levels and risk of depression. Fact or myth? Need some clarification? What do you think that might mean? Just like what's the informal part of caregiving? All those parts, the drop-offs, the pickups, breakfast, lunch, and dinner. So it's actually a fact. All right, let's see. So mental health issues during pregnancy or postpartum are just the baby blues. Absolutely a myth. Don't downplay what somebody's feeling, right? So women can power through depression with power thinking, with positive thinking. Yes. Is it a myth or myth? Definitely. All right. So women account for approximately 85 to 95% of those with anorexia and bulimia nervosa. Fact. Okay. Then lastly, so women are twice as likely as men to develop generalized anxiety disorder, panic disorder, and specific phobias. Fact. Nice job. All right. So some of these learning objectives I put up here, really it's about understanding the biological, social, and cultural factors that show up when we think about the mental health aspects for women, identifying and evaluating the primary barriers that women face when seeking some mental health care, and then comparing the effectiveness of standards of mental health interventions and thinking about it in the context of decolonizing half of our practices or all of our practices and thinking, hey, how can I apply this to women and the women of color? And develop strategies for implementing some gender responsive mental health services that address our unique needs. All right, so just for some trigger warnings, right? So I'm not sure why the font came out super large like that, but we are going to talk a little bit about suicide. We are going to talk a little bit about trauma, complex trauma, and then we are going to touch on a little bit of sexual assault and coercion. Still don't know why I came out like that. All right, so some of the therapeutic modalities as therapists, when we are doing our work, we are trained in a few of these areas. And some of them are specialized areas. So we have EMDR, which we use for trauma. We have interpersonal therapy, which really helps with depression and trauma. We also have cognitive behavioral therapy, dialectical behavioral therapy, solution focus, some mindfulness-based cognitive therapy, and somatic health therapies as well. So when I talk, I put the asterisk next to the mindfulness-based cognitive therapy and also cognitive behavioral therapy, because those are two of the modalities that I use. But my jam is narrative therapy. It's my jam because when I pay homage to where this therapy comes from, we really think about the power of storytelling and how when a person is impacted with something that they define as traumatic or perhaps depression, anxiety, it's the concept of being able to tell stories. And in my private practice, when I work with my clients, which are 85% women and women of color, the goal is to get them to tell their story. It's really challenging for folks to feel like they have the floor and not be interrupted, to talk about what they've been through. And if you think about yourself along your own journey, just think about, did you ever have the opportunity to sit and tell your story? And if you haven't, ask yourself why. So when we think about this concept of storytelling, I did not do that. No, I didn't do it. Don't know what happened. But anyway, I'm going to keep going. Okay, so when we think about storytelling, we think about the concepts of where did it come from originally. So when we think about African culture and the use of ancestors, the use of the person who's wise, the elder in the community, that was the power of storytelling, right? You go, you hear what has happened to people along their journey, you hear those next steps. When we think about folks who are Native American and First Nation, same thing, the powers of elders who tell story, the wise ones, right? So that's storytelling. And then when we move into narrative therapy, we talk about, thank you, transparency, right? Our transparency is not weakness, it's our courage. How do we find that courage to tell our story? So if I ask you, how many of you have a story to tell? I'm not going to ask you to tell me the story, but how many of you have a story to tell? That you've been through some stuff, right? Along the journey, some stuff has happened. That's fine. And not everyone feels that as if they can tell that story because it feels hard. And like if I do tell a story, who's going to listen to me? And if I tell it, are they going to judge me, critique me? All right, so when I use narrative therapy, I talk about the concept of how we use mapping. And so what I want you to do is to think to yourself in all these areas, so childhood, preteen, 11, 12 years old, teenage years, 13 to 19, early adulthood, 20 to about 25. Adulting, we're just going to call that from 26 up, and then what's happening today. Okay? And I want you to think in these areas. Did anything occur in one of these areas that was substantial to your upbringing, your life? Now, again, I'm not asking you to share it with the room, but just think. Did anything happen in one of these areas that still weighs on your mind and kind of changed how you are today or changes how you interact with people, how you trust people? Right. Now, if I asked you to show of hands, how many of you would say that that thing occurred in childhood? Okay. Preteen. Okay. Oh, and there might be more than one thing, right? Okay, so we know that. Teen years. Okay, right? Early adulthood. Adulting? Oh, yes, chess. Yes. Something always happens in adulting. I will not lie to you. And then what's going on today in your life, right? So when we talk about narrative therapy, we're trying to take away the person from thinking that they are the problem, that I'm the problem, that something happened along my journey. And I have to get to a space where I feel really comfortable about realizing that I may not necessarily be the problem. I can accept accountability for things, but the problem isn't me. I have to separate that into my story and walk myself through what happened, and then now learn to re-story my story, okay? Okay, so we're going to talk about a little bit of statistics. Again, font so big, don't know why. So global statistics at the top. So women are 2 times more likely than men to experience depression. Anxiety disorders affect 23.4% of women worldwide versus 14.3% of men. But I also want you to understand that when we look at these numbers, these are reported instances. There are people who don't talk about it, that story. There are folks who just live with it and don't go to a doctor and say, hey, I feel like this. And then these statistics down here are from the United States solely. 1 in 5 women have experienced a mental health condition in the past year, and that was in 2023. 1 in 5. So if I go 1, 2, 3, 4, 5, one person. 1, 2, 3, 4, 5, one person, right? That's how that would sound. So women attempt suicide 3 times more frequently than men. Now, the difference here is the method. Men are documented as trying to attempt suicide or completion of suicide with more egregious ways, such as firearms. But women tend to use the cutting of wrist and pills, overdosing. Then we look at a 1-year study and we say, okay, let's look at the prevalence of depression. It was noted that 8.7% of women identified as having depression versus 5.3% of men. A few more statistics here, and I highlighted some in pink that I thought they stood out a lot. So that access to treatment, those barriers that kind of come in our way in order to gather that treatment, to seek some help, to tell someone how we're feeling, right? 60% of women with mental health conditions don't receive any treatment. That's a lot of people. And the average delay in seeking for treatment is 2 to 3 years longer than men. So think about when that person or yourself, everything's fine. Oh, I'm fine. When I mean, when everything's on fire, and you're like, I'm fine, everything's good. I hold everything in, I keep going, and I keep going. And I talk about being the strong woman. Be strong. Take everything in, do everything on my own. Don't say anything to anybody that I might be suffering. That's where this comes from, that delay. It also comes from insurance, having access to insurance that gets you to an appointment. Some folks may have insurance, but also have deductibles that are super high. So when you have that appointment and you can see someone, your out-of-pocket cost is over $100. That's typical. Then the economic impact. If we have more people go out on disability, then we have less folks in the workforce. So what they're saying here is that there's an $800 billion deficit when folks are going on their medical leave for a mental health issue. And 58% of disability claims for mental health are filed by women. Then some socioeconomic factors that women in poverty are 3 times more likely to experience a mental health issue. Single mothers show 4 times higher rates for depression, and working women experience 50% higher stress levels than their male counterparts. Remember that informal caregiving? Okay. Extra load. And then when we talked about, when I had you raise your hand and say, hey, what happened in those adolescent years or those childhood years, right? Looking at things that occur during adolescence and why it's important. So we have higher rates of anxiety and depression that emerge at this time, eating disorders that are developing, and then think about social media, how I look, what my body looks like. My 9-year-old niece told me that she was part of a group called the Baddie Girls. What is a baddie to you? Right? So how do you know what that means? And I'm sitting there, I'm like, tell me what a baddie is. Oh no, I can't tell you. You know what it means. And I'm like, how do you know? Well, she knew. Right? And then to tell herself, we're part of this group. How do you quantify yourself as being such? Okay. Then some key statistics. 20% of teenage girls experience major depression annually. So during the pandemic, we saw a large amount of teens going on the Mental Health Association's website to take the quizzes for depression and anxiety, which led to an increased outcome of folks who were in this age range, 12 to 19, being diagnosed with anxiety and depression. And then we have those reproductive years. And in reproduction, first we got to think about the first decision is, do I want to be a parent? Because you don't have to be, but that's part of what happens during this time as well. So most folks who decide, I don't want to be a parent, use some form of contraception, and that is their choice. Then we also have PMDD, premenstrual dysphoric disorder. Now, the only way to get this diagnosis is if your symptoms occur for a minimum of 1 year. That means with every menstrual cycle, there has to be a 2-week period where there's intense mood swings, irritability, frustration, depression, anxiousness. All of those things have to be present for 2 weeks, 1 year, in order for a woman to be diagnosed with PMDD. Now, what if I had 1 month where I didn't have it? I gotta start all over again? That's what our DSM says. Okay. So then we have career and family, balancing that, the balancing act of do I want to be a working woman and my goals? Do I want to be, and I want you to understand, choosing to be a stay-at-home mom comes with its stressors. It is a lot on people. So sometimes we don't think about the fact that a person has chosen to be a stay-at-home mom, what that load comes with. You are always home. You are always on. You are always available. Then there's fertility challenges. So for folks who can't easily conceive, what does that feel like for them? Workplace discrimination and harassment. And harassment that comes from your colleague, harassment that comes from your supervisor, and then higher rates of trauma exposure and PTSD. So I put this next slide in. For some of you, how many of you have watched this show on Netflix, Adolescence, right? Oof. Now, I used to watch Euphoria too. But this one here, ooh, okay, we have a young man, well, a young woman for first, let's say 13 years old, she dies. She's stabbed to death. But then we have a young kid, right, classmate. And we're thinking about that sense of social media. So we talked about with women, that sense of social media and how we look at body and our image, what my hair looks like, my skin complexion, my texture of my hair, how I dress, my weight, everything about my features, makeup, all the things that we look at and we kind of compare. What do you look like? What do I look like? But then this one hones in on boys. Toxic masculinity, that's the term that people talk about a lot, right? And it talks about how being bullied alienates a person, puts them into isolation. And then what it really kind of goes into is the fact that there are incidences where there's crimes in this particular area of Britain that are against young girls. So even though this may not be about really the young girl. It's this story here. But think about how those numbers for crime against young girls have increased. It's not okay. So some cultural considerations. So we think about all the things that we talked about, right? Things that happen, those statistics. But now culturally, how do we break this down? So in those adolescence years, we're thinking about academic achievement. Do you come from a family that says you need to get those good grades? If I'm paying for your education, you need to get good grades. I expect that you come home with those good grades. Pressure, right? Family obligations. Being first generation. Do you translate for your parents? Have you translated for them in the past? Are you the oldest sibling who takes care of the younger siblings? Did you pick up your younger siblings? What was your responsibility? Those beauty standards, right? What that means culturally. So there can be our societal beauty standards. But what about within our culture? Does our culture prefer a woman who's slimmer? A woman who's curvier? And then if you're not that thing, how does it make you feel? Is your confidence as high as it would be if you didn't think about that? Then those religious practices. How do they affect your decision making? How do they impact how you decide what I do next or not? Is there a pressure that resides there? Then cultural stigma around mental health. Can I even talk about what I feel at home? Is my voice heard? And then the impact of acculturation stress in immigrant families. So now when we move up to those reproductive years, right? Think about that pressure. Are you dating? Are you going to bring your partner to Thanksgiving or Christmas? And then you finally bring a partner. That's my partner. Are you getting married? Well, no, we're just dating, but you should be getting married. Okay, so now you get married and you're like, okay, I'm married now. Are you going to have kids? Okay, not yet. I'm going to finish, I want to finish work, I'm going to do some things, I'm going to travel. Okay, so are you going to have kids yet now? Okay, now you have your first baby. Before the first baby gets here, so are you planning for 2 kids? You want 2? The baby needs somebody to play with. They need a sibling. You should have them close together in age so that they can go to school together and grow up together. So you're just going to tell me everything I need to do with my life. Depending on what culture you may come from. What is acceptable? And one of the things I like to talk about are boundaries. And when you set those boundaries, sometimes when I talk to my clients and I'm like, okay, let's just first talk about what's acceptable. So if I say, set a boundary, I think about talking to my mother and telling her, well, you can't talk to me like that, or you can't do this, or you can't say this thing to me. I might get slapped as an adult. And I'm just being honest, okay? So when you think about your parent, and me, I know I'm Caribbean, you're not going to talk to your mom a certain way. And then if your mom feels hurt and offended, you hurt my feelings, and now they start crying, and you're like, manipulation. But you can't tell her she's manipulating you. That's not okay. So what boundaries are appropriate when you want to say, hey, I'm not really ready to get married. I'm not really ready to have children. Then those gender roles, right? How you may identify or not. And what happens in those spaces? Can I talk about how I identify? Can I talk about the fact that I don't want to do inside housework? I don't want to be domesticated. Then those cultural beliefs about fertility and reproduction, things that people say, community expectation as your role. So if any of you in here are parents, or if any of you just kind of scroll through TikTok or Instagram, people telling other people how they should parent their kids, discipline their kids. Oh, well, you shouldn't use those kind of wipes or Pampers. Are you going to buy me some new wipes and Pampers, right? All those things that come about. So this is what happens culturally when we think about what women think to themselves. Then there's that pregnancy and postpartum period. And even though those statistics that show perinatal anxiety affects up to 20% of women, when we do perinatal mental health, we realize that part of the risk factor that elevates this risk for perinatal mental health issues is most likely because that person did have a mental health issue prior to. So maybe there was some anxiety there before, but they didn't acknowledge it. Depression was there before, but they did not acknowledge it. Then if we look at traumatic birthing experiences, that increases that level of anxiety and or depression. Being able to think about your sleep. If a mother chooses to breastfeed, you are now the sole provider of food. And if you don't pump, put it in a bottle, no one can help you. You're on your own. So these are just choices that women have to make. What kind of help do I need? What's expected of me? And usually when I give a presentation on traumatic birthing experiences and perinatal mood and anxiety disorders, I talk about the fact that people, how many of you have heard of doulas? Right? So doulas are there to help the person who is pregnant, help you in the hospital, be there with you, your support team, all those good things. But there's backlash sometimes when people use doulas. So we hear the positive reviews about why it's important to have a doula, the success rate of having a doula, how people feel more supported when having that doula. However, when they have them, and I've seen folks post on social media, like, oh, I had a doula, I had a nighttime nurse, I paid this much money for it, but it was what I needed. Comments are very negative, like, that's what moms are supposed to do. You're supposed to be a mom. What does that mean? Does that mean that you don't deserve support? Does it mean that you don't deserve sleep? Right? So you have to think about how women think. And if all of these thoughts are being put onto me, then how do I know what to do next? Or do I feel bad about sharing with people that I paid for this extra service? Then menopause. How people feel during menopause. What happens here? Right? That fluctuation in hormones, being more susceptible to depression and anxiety because of those hormonal changes, role transitions, but then also in the brain, this concept of, even though you may not have wanted any more children, but now it's like, oh, it's finite now. I really can't have any more children. That decision, that part alone is the part that increases that level of anxiety and depression. So again, just reiterating, a person can have had all their children and they could all be in college and working and doing all the great things. But when menopause hits, the brain goes to, oh, this is over. Even if they didn't want to have any more children. So the brain still goes there. And then some of those cultural considerations in these areas. Okay? What practices are the norm within a particular culture when it comes to pregnancy and postpartum care? Who's there to help and support? So different cultures have different customs. Here in the U.S., how long is maternity leave for most folks? You know? Just 6 months. That's a luxury. Say it again. We said 2 weeks. Say it again. 6 weeks, a little bit longer. A little bit longer. A little bit longer. Here you go. There you go. Right? You may get somewhere between, depending on your job, 2 and 3 months. Right? So you have to come home, recover medically, however you had your baby, how your labor went. And then from there, you have to take care of your child, bond with your baby. Then you have to find appropriate care. Now, in this modernized world that we live in, that is not a collectivist culture, it's individualistic. But if you come from a collectivist culture, things are different for you. The way you think about pregnancy and postpartum is very different, being from a collectivist culture. Being from an individualistic culture, you're going to think, okay, childcare, check. Get the daycare down, put you in daycare, go to work. But in another culture, that may not be okay. Okay. Realizing that extended family is heavily involved in collective cultures. Realizing that there could be stigma on how you raise your children. There could be stigma on how you take care of yourself, what you eat, the processes that happen during pregnancy and postpartum. And same thing here for menopause. And that openness about being able to discuss what happens during that time and how one feels. They feel embarrassed about sharing with people, especially if they're judgmental. Think about how many of you actually want to share something with somebody who's judgmental? No? You don't? No? Okay, cool. See, I didn't think so either. Me either. I don't want to share with anybody who I think is judgmental, because why am I talking to you, right? And then some common factors across, I don't know why again, factors that come across during these stages, right? So we have trauma history. Again, what has happened to people? What have they lived through? We have sociocultural and socioeconomic challenges that stand out. Where I live, my cultural background, how much I make. How much I make impacts my quality of care, unfortunately. My income, my insurance impacts where I receive care from. The type of insurance I have impacts the quality of doctors that I see. Not too great. Which also then hinders that limited access to health care, and then social support and some deficits there. And then we have some protective factors, right? So we use that term protective factors when we talk about suicide as well. Things that are risk to suicide, and then things that are protective factors. Same thing here when we think about what's happening to folks. What are some protective factors? Well, having a good support system. Family or friends, whoever. Family by choice. Access to quality health care. And so a lot of times when I talk about Black maternal health and access to quality care, it is not that every person who identifies as Black or brown says, I must have a Black doctor. It is that we recognize there may be a shortage in some areas, but what I really want is a doctor who listens. What I really want is a doctor who provides me with quality care, who understands my concerns. A doctor that I can express why I feel and think this way. A doctor who's going to have my back. So that's what's important too. Then protective factors, physical activity, right? So when I say physical activity, I don't mean that you must go to the gym. Physical activity means go for a walk, move your body. It helps your brain and your neurotransmitters. Stress management, how you manage the stress that you go through, and early intervention and treatment, which we saw was a 2 to 3 year delay for women. So these are just some cultural considerations across all stages that I put on this slide. And then intersectionality. Why is intersectionality important, right? So we know that Kimberly Crenshaw kind of put the term together for intersectionality, but prior to her putting that term there, folks were talking about what this experience felt like. What it felt like when I identify as a woman of color. When I also think about my health care, when I also think about my family, when I think about all the things that I carry, and then on top of that, that leads to how somebody else can discriminate against me. Or how I can't get a certain job. How there's systemic racism, oppression, things that people feel daily. How I show up in a space. Am I the only one who comes into space? Recently, I had that experience, and I haven't had that experience in a little while, right? I've been pretty good with having well-versed spaces, diversity, seeing all the beautiful faces, but recently I went to be a judge at an event. And I walked into the room, I was like, and I didn't even notice it, talking to people. Hi, good morning. Coffee strong, right? Hi. And then I realized when I was walking through to do the judging for all these poster events, that I was the only black judge. I wasn't the only woman, but I was the only black person in the room. There was no one else of color. And then I thought to myself, well, okay, if I see that, they see that. That means all these students who are undergraduate students, just like you, were there with their posters. And it was like, oh. And then I could see when I ran across certain students who were brown, would look and say, oh, sigh of relief. But that feeling is real for people, right? That feeling of how am I going to be judged, perceived, seen, and all the things where parts of me show up. All these spaces, right? And then, my favorite one. Just because I carry it well, doesn't mean it isn't heavy. All the things that you carry. Now, if you add on top of that, being a person of color, however you may identify, that's added into this load. Because now I think about, even though I may not necessarily walk into the space thinking, okay, this is what is happening. No, but when I walk into the room and I see that I may be the only person or I'm experiencing this, that's not a great experience to have. It kind of singles you out, makes you feel alone, isolated, and you're like, okay, how do I keep this going? Keep this up? What's my next step? So, realizing that when we are in practice, whether we are nurses, doctors, therapists, we have to remember what people are carrying and how it shows up for them, what it means to them. And so here we talk about a little bit of anxiety and depression. So these are just some ways that depression will manifest for women. So we have those physical symptoms, emotional manifestations, and then behavioral signs. Things that we look for, but realizing that this most likely shows up for women. When we think about men and depression, it's a little bit different. Even though our DSM says, oh, these are the symptoms, the way it may show up for men is different. So thinking about that change in appetite, being fatigued. But like, how do you really define fatigue? You're all students, so aren't you tired? How do you know the difference between being tired from the load that you carry and fatigue? It's a good answer when you're getting a sufficient amount of rest, but you're still tired. Like, I just can't shake this feeling, right? Any of you still tired? Changes in your appetite or your weight. Now, for women, I think about that appetite and weight. When we just said during premenstrual cycles, menstrual cycles, you have to, changes in weight, fluctuation, mood. All these things still show up and it's trying to define, is this because of this or is this my overall experience? So just paying mind to things and how they show up for women. All right, so I'm going to fast forward a little bit, but these are the common manifestations of anxiety in women. And then in trauma. So I just wanted to go through trauma really quickly because trauma is really important, because we have learned that since the pandemic, the number of people, the percentage of people who have expressed experiencing trauma has increased significantly. We went from a 30% of folks who identified having at least one traumatic event in their life to up to 67%. So that means that in our work, in your work as nurses, my work as a therapist, that we are going to encounter people who have been through some sort of trauma. We are going to also come into contact with people who have been through complex trauma, long-lasting experiences, over time, repeated trauma. All right, and then that prevalence of trauma. So women are twice as likely to develop PTSD, from a 10% to 4% for men. And 1 in 3 women experience trauma during their lifetime. Interpersonal trauma is more common in women. So by interpersonal trauma, we're talking about women who have experienced sexual assault, coercion, date rape. That is experienced at a higher volume than men, which also then brings that number up for acute stress disorder and post-traumatic stress disorder. And then elevated risk when we think about when folks are exposed to one sexual assault, that likelihood of being exposed to a second one increases significantly, unfortunately. Okay. And so I'm going to skip on over. So when we think about trauma in the brain and how it impacts us, we think about our prefrontal cortex, how we make those decisions, our amygdala, and our hippocampus. So when we look at this, when we have been through trauma, significant trauma, how it impacts us, that our prefrontal cortex, where we make those good decisions, do our homework, show up for class, answer, put our hands up, that shuts down. And what takes over is our amygdala. Our hippocampus kind of like revs it up and says, hey, all these memories, all these flashbacks, all these things that happened before are still here, and your body is now responding. And those physical symptoms, and the amygdala says, we got to get out. We're fighting for our life. We have to get out of this. So alerts are on, fear center is charged up, and this is how people are operating from these two areas, not necessarily their prefrontal cortex. So that's why it's important that we talk about trauma and how folks respond to us in treatment. And so just here are those manifestations for trauma, those physical manifestations, body and memory expressions, how we feel it in our body. So what happened to us and what we feel in our body returns the moment that we feel that trauma has been triggered. And then those psychological manifestations at the end. Okay. So maternal health, we kind of talked about a lot about this, but I'm just putting this here as a statistic because we also see that only 15% of birthing persons, mothers, receive some type of treatment for perinatal mood and anxiety disorders. So that means that folks are going through their pregnancy not really talking about how they feel, not expressing that sense of, I feel a little anxious. I feel worried and concerned. And if I'm a person of color and I'm thinking about all the things that have happened in our administration and what's happening in the world, now I may be thinking, am I exposing my child to this and what happens next? Okay. So I'm going to stop here. I know we are at our time, and I just want to check in if anybody has any questions. Yes.
Hi.
Hi.
I feel like people typically have like some type of unique experience or trigger that sparks their interest in a specific field. So considering you went from a kindergarten teacher to then case management, I was wondering if you have any unique experiences that you want to share with us that got you from there to where you are now.
Okay. Well, I didn't necessarily want to be a kindergarten teacher at first. It was like my mom was a teacher, and then I needed a job after college, so I took a couple of the teaching exams, and I passed them. And it was a job that opened up. I wanted to first go into some type of case management initially, but it was really hard to get into that door. So I had to work, and I was supposed to work as a cluster teacher, and I was supposed to teach like English and writing. But they were like, oh no, we want you to teach kindergarten. So I walked into a kindergarten class like, how do you teach these little people how to read? So my mom had to teach me how to teach small people how to read, like sight words, how you build a sentence, and all that stuff. But what actually happened when teaching kindergarten, there was a little girl in the classroom, and we all taught in psych, right? You know this thing. She started drawing these black circles, like a family, and a person was off to the side, and he was like a stick figure, and he was crossed out in a black circle. I was like, oh, this is what they taught in class, trauma. Something happened here. And then one day, so I was like, oh, who are you drawing? She wouldn't say anything. So the next time we had class, I'm talking to her again, and she said, well, I need to go to the bathroom, but can you go with me? Downstairs hurts. I was like, I can't do this. So as a person who worked with kindergarten children, I knew that if I had to do therapy for kids and I had to be a kindergarten teacher, I needed to help more. I needed to find a way to help more, because in that situation, all I could do was make a phone call. So I knew there that I needed to shimmy on over to behavioral health because that was my world.
Thank you.
You're welcome. Anybody else?
Any other questions? Yes. So you spoke a lot in the beginning about narrative therapy. Can you speak about any challenges with those that type of therapy? Because number one, people are not used to talk, like you said, speaking your own story and unpacking. So can you speak more about any challenges during that therapy, or maybe people who say, this is too deep, I'm not coming back?
So I changed how I do my intakes, and most often when we do intakes, and I'm pretty sure you've talked about intakes as well, it's about us asking those questions to our clients and really figuring out, okay, hey, what has happened to you? So I changed it, and I made the intake documents that they could complete before therapy started. So they would have to answer all the questions, and then I would receive them. And so when I first started my session, the way I begin is I always ask myself, okay, I'm going to set the tone for you. I give you the floor to walk me through what has happened the last 3 months, three to 6 months in your life. And then as they're talking, I then ask clarifying questions. Sometimes it's hard for folks to kind of go into that detail, but I give them a shorter window to start with. And then I tell them, okay, as we go forward, we may have to go back a little bit so I can understand what has happened and then where we want to go. I also empower people to make their own goals. You tell me what you want to work on in therapy. And rather than me saying, you must come to therapy every week, I let you do that. You tell me how often you want to come. Do you feel that after we have met this first time that you are ready to share some more? If you are, then I empower you to start and do it every week. If we've been together for a little while in therapy, it's time to graduate a little bit to bi-weekly, every 3 weeks now, maybe once a month. So the challenges with narrative therapy can just be the idea of opening up. And there has been times when folks will tell me they've been through trauma, but they like to do it at 4:58 p.m. and the session ends at 5. So, Dr. McCants, yes, as we wrap up for our next session. So, it's Thanksgiving. I just wanted to let you know that next week my uncle's going to be there. And, he's also the person who sexually assaulted me for 10 years. Wait, excuse me. 4:58 p.m. We end at 5. Okay. You know what? Thank you for sharing that with me. I appreciate you. And we'll jot that down and we'll come back and circle back to it. So sometimes those are the barriers that folks aren't ready to share, but I really try to work on the timeline. Let's just start where you're ready. If it's with today and we go backwards, that's cool. If you want to start from the beginning and go forward, that's fine too. Anyone else? Yes, go ahead.
Okay. Well, first, thank you for this presentation. Currently, I'm in a class, and we're looking at ethnomusicology, and we learned about a woman who did her type of research by walking, and how walking helped her get to meet people and get to know people. And so, just by listening to you speak, and based off of Dr. Barnes's question about talking and narrative therapy, how would you say that has helped you, but also your practice of getting people to open up, but also do you find that to be the best method of therapy? Thank you.
Well, best for me?
For the best method of you to get people to open up about what they've been through, but also to get to achieving their goals.
Yes. So I do like narrative therapy because I can do the mapping part and restoring the story. But I think another one that I also work with, the mindfulness-based cognitive therapy, where we do more of holistic. So I'll have people do meditation, we'll do breath work, progressive breath work, some yoga techniques, or I'll give them like some videos to watch. And during the pandemic, when folks couldn't do much, we used to do like walking therapy. Like, okay, I'm gonna go outside for a walk. Are you gonna go outside for a walk too? I'd have my headphone on and walk while I was talking to some people to encourage them to use that movement of body. So I do realize that when we think about the neuro counseling and the neurotransmitters, that when you move your body and you do breath work, it helps you. And all those neurotransmitters in your brain and your body kind of like check up a little bit, right? We want to change some things so that we can process better how we manage anxiety, how we manage depression. So yes, I do feel that for me, as a clinician, I like the use of narrative therapy, but in conjunction with mindfulness-based practices.
Okay, thank you.
You're welcome. Right. Oh, yes.
Okay, sorry. Hi, Dr. McCants. Thank you for your presentation.
Yes.
My question it's a little loaded because I'm like thinking of everything you presented. And so, for instance, your work using narrative therapy and some CBT, so it seems like you have like an eclectic approach to using the modalities. So based and thinking of women, like in families, whatnot, friends, but more so women in families, where I'm thinking like mothers and their relationship with their daughters, grandmothers, whatnot.
Yes.
And your little spiel about boundaries. I'm wondering how you use your work to help folks, especially those from the Caribbean, West African. How do you use your work to help people that come into therapy or people that you walk through like setting boundaries compassionately? Because like you mentioned, sometimes you do talk to parents, or like you, as a client, you talk to your parent and the parent will start crying because of what they said and the manipulation, all that. So I wonder how you help people go through that and, like I said, compassionately set boundaries.
Right. So first, that was a really good question.
Thank you.
I really try to work with folks on, let me just tell you what boundaries are. Right. So psychoeducation first. Let me just say what they are. And then I will ask, so also let's talk about cultural aspects, how you grew up, your cultural identity, how that plays a part in who you are and your relationship with the people you're trying to set the boundaries with. Maybe it's a little different for you. Like I said, certain cultural practices and certain groups of people will say, hey, there's no such thing as privacy. What do you mean close the door? We all in here. Or if you want to have a medical procedure done, the family has to make a decision on that procedure. So I try to get folks to open up about that part first so that I can understand how I can help you set boundaries and how boundaries are feasible for you. Maybe for you, it's not saying I don't want to do this with my family, but maybe for me, it's I need to take a walk. I need to step out of my house. Maybe I need to get some air, go to dinner with a friend, and then come back into the home. I've had clients who've had fathers who are very dominant within the culture and the family. So it's patriarchal, and dad makes a lot of those decisions. So they have to kind of say, hey, I want to do this thing, but dad is like, no, you can't do that thing. Oh, I need you to marry this kind of person or a person in this religion or a person of this culture. I can't stop dad from feeling what he does, but my job is to help you feel better about what your decision is, and if you feel like you want to say something, or if you'd rather step away from that situation. So I really take it on a case-by-case basis because that's important for me to understand first and foremost.
All right, so we are going to wrap up. If we can get a warm round of applause for Dr. McCants. And her workbook is at the back if you want to explore her workbook that she published recently. And also, you can follow her on LinkedIn and reach out for personal questions. And she's actually one of the people who responds, because some people on LinkedIn don't respond because there's so much spam going on. And thank you so much for being a captive audience. And again, special thanks to Hofstra Cultural Center. Let's give them a round of applause for making this event possible. and National Public Health Week. Thank you so much, and please look for more National Public Health Week events.